Some of this stuff is a little more difficult than is probably what is asked on the website, but some of it is not, and so it's very fair game. A lot of this was originally done by Dr. Percival, and then I updated it and added some stuff at the end. There's not a lot of esophagus in this because there will be a separate esophagus lecture. So let's see. Okay, so thoracic surgery and cardiac surgery are both very simple. If it's cancer, try to take it out. If it doesn't function, try to fix it or take it out. So we'll start with just kind of thoracic, and then we'll start with anatomy, and then we'll go to cardiac. So just some kind of rapid fire anatomy questions. Serena, what does the azygous vein drain into? It's a SVC. Connor, if you're asked anterior versus posterior, the phrenic nerve runs anterior or posterior to the hilum? Okay. Yes. Yeah. Carson, what's the role of type 1 pneumocytes?
Type 2 produces.
So what's the role of type 1 pneumocytes?
Type 1 is the movement of air.
Yes, air movement. So Todd, what's the role of type 2 pneumocyte surfactant? What level does the thoracic duct? What level does the thoracic duct cross at? And in which direction is it going? Correct. So from right to left at what level, Frank?
T5.
Yeah, T4, T5. Perfect. Okay. And then Jamie, about how many pulmonary segments are there? 18. Good try. So, yeah. Carson, how many on the left, how many on the right? Or more on the left, more on the right? More on the right. Serena, why is that? Yeah, well, I mean, the heart kind of compresses what would be the left middle lobe, and that's why we have the lingula instead of the left middle lobe on that side. So there's 8 on the left, 10 on the right. And then we're going to go through and we're going to start naming these. So Todd, on the right upper lobe. Do you know any of them? There's 3. Okay, so there's apical and anterior and a posterior. Connor, middle lobe. The right middle lobe, it follows, if RML is the acronym, that could be used as a mnemonic to remember the segments of the right middle lobe. So medial and lateral, right? Medial and lateral. It's different between that and the lingula. And then for the lower, it is just, there's a superior segmental branch and then all 4 cardinal directions, anterior, medial, posterior, lateral. On the left upper, so if you see here, you have apical and posterior. Here it looks like they take off of a common trunk. So that is your apico-posterior, and then your anterior. So very similar, left to right. If on the right middle lobe, we have a medial and lateral, and then you switch cardinal directions here. So it's a superior and inferior. And then here, you have all the same, you have a superior segment, and you have all the same cardinal directions except for a medial basilar segment because the apex of the left ventricle is in the way. So it's actually, if you can remember the right side anatomy, you can remember the left side anatomy and account for the heart. Okay, so this is more likely to be asked on the exam, are these flow volume loops and kind of what are different capacities and what are different volumes. So things to remember, capacities are going to be all of the individual measurements, right? A volume is a combination of 2 or more capacities when answering these questions. So we'll start with just kind of this. What this box, it demonstrates kind of normal respiration at rest. Serena, what is that tidal volume? And sorry, I may have misspoke. I think I said I said volume is a combination of capacities. Capacities are a combination of volumes. Thank you. So if how much we can breathe in above our tidal volume represents what, Carson? Inspiratory reserve volume, right? Yes, yeah, these are all going to be individual things. They'll all be volumes. And so inspiratory capacity would be a combination of two volumes. And then so how about how much you can breathe out after having taken a tidal expiration, Jamie? It's not inspiratory reserve volume. Yes. And then after you take a maximal exhalation, the volume left in the lungs, Frank, when you're done, you cannot exhale this amount. Or residual volume, but yes, same acronym. And then, so Carson, you kind of are answering this, but not just the volume above your tidal volume, but so this level is your FRC, this level at the tidal kind of exhalation, that's kind of the resting volume of the lung. So your entire ability to inspire would be, yes. And then, the corollary to that, if you're not inspiring, but you're expiring, Todd. So that's FRC, right? So this is the volume that is kind of in your lungs at rest. This is the volume that, by adding PEEP and other things, you raise your FRC. That is sometimes brought up as like a physiologic corollary, for people who are going to have, atelectasis, it's going to decrease their FRC, decrease the functional area of the lung across which gas exchange is occurring. And then so this, you can see the arrows go from all the way at the bottom to all the way at the top. Connor? Total lung capacity. And then Frank, if you exclude residual volume, what capacity is that? Yes. Yeah. It's a better functional measure because, great, people have residual volume, but it will never really be involved in your air movement. So kind of who cares? These flow volume loops, we will move through kind of quickly because I think they're unlikely to be asked, but this is a normal flow volume curve. Important to know, there is no time axis on this. So this is a loop, right? This is the flow. So flow is very high early in expiration and it should kind of taper down. And then you should have negative flow during inspiration until you reach your baseline again. So this goes around and around. There's no time component here. I think sometimes that throws people off thinking the graph moves to the right or something. It's just a loop. Mm-hmm. Yeah, and we'll go through the examples of obstruction in a second. So if you have a obstructive physiology, you have an early decrement in your flow that's very rapid. So things like COPD, whether that's asthma, emphysema, chronic bronchitis, but this is an obstructive pattern. If you have a reduced ability to achieve a total volume, but the flow appears normal, that is a restrictive lung problem. Things like pulmonary fibrosis, obesity can cause that. And then now we get into kind of the areas of obstruction. So it's kind of a difficult concept to think about, but if you are inspiring, the intrathoracic pressure is negative. And so when you are drawing air into your lungs during inspiration, there's an outward pull on your airways inside the thorax. Outside the thorax, it's negative pressure inside the windpipe that actually would drive kind of collapse. So if you have obstruction during inspiration that is isolated, it is probably an extrathoracic obstruction. Something external to the thorax is causing that obstruction because there's a collapsing force on the extrathoracic airway that is being magnified by some other variable. Versus if you are expiring, you have positive pressure in the chest, you have a collapsing force on the intrathoracic airway. If you have expiratory obstruction, that is something that's intrathoracic. So this person, they can breathe out just fine. They have obstruction when they breathe in. So because it's not in the whole respiratory cycle, you say that's a variable obstruction. And because it's during expiration, you would say, or excuse me, inspiration, you would say that it's extrathoracic. So this is a variable extrathoracic obstruction. Things like vocal cord dysfunction, goiter, laryngeal tumors, things that affect the extrathoracic airway would cause this. Yeah. 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 This, you see the patient, they cannot exhale. So this is when you have a positive force on the intrathoracic airway. So this would be a variable intrathoracic obstruction, something like an endobronchial tumor that's acting as a one-way valve and causing air trapping. Yeah. Also, COPD will be more like this, but this would be like a large airway obstruction, intrathoracic. And then this is a fixed stenosis where both parts of the loop are truncated. That's like a completely obstructing mass that, you know, does not allow a one-way valve function or movement of air. Yes, yes, in their ET tube. Yes, but unlikely to be so bad in their native airway because they would have to have total main stem tracheal mucus plugging, which they would be dead.
And this is the,
but yeah, or someone biting their tube. Yeah. Okay. So in terms of, you know, you're getting ready to take a thoracic surgery patient to the OR. We'll just kind of keep going through some questions. So greatest predictor of mortality after a lobectomy, Jamie. It's actually DLCO. FEV1 is very frequently tested. It's something that we drive home in terms of pre and preoperative values, post-op predictive values, but the most sensitive predictor of mortality after a pulmonary resection is a DLCO. And we'll go through that a little bit. So what you want pre-operatively, so these are variables that would make someone low risk if their FEV1 pre-op is greater than 60% predicted, DLCO the same. If their post-op predicted FEV1 is greater than 800 mLs, they'll probably be okay. And then post-op predicted, these are numbers that seem to come up a lot. So post-op predicted DLCO or FEV1 greater than 40%. And then if you are close or you get a quantitative VQ scan and it's still close and you get cardiopulmonary exercise testing, the VO2 max should be at least 15 is what I would take home.
What is to look at gas exchange in the lung or area of concern relative to the normal side. Yeah, so if you're going to resect the lobe and there's a big tumor in there, gas exchange there anyways, when you get your pre-op testing, it's going to have a lower, so, but when you subtract that out, it's going to overestimate how much real lung function you're on. So it can allow you to take out
Yeah, exactly. So anything that is relatively obstructing, you know, the downstream pulmonary segment is probably not participating in gas exchange, and that will help you quantify that. So if you're thinking about how to work someone up in terms of their pulmonary function before going to the OR, you know, you're going to always start with your spirometry and PFTs. If that is close on the ab site, you would then go to a quantitative VQ scan. If that is close, you would then most likely go to cardiopulmonary exercise testing. Would be kind of the algorithm that I would work through. And then here they have at the bottom, same kind of things we talked about. Patients that are okay in terms of their preoperative risk, you know, post-op predicted FEV1 and DLCO greater than 40, and then a VO2 max greater than 15 on that cardiopulmonary exercise testing. They are not going to ask you about patients that are marginal other than to say, what would your next test be? Or if you are given a patient that is clearly prohibitive risk and has a small lung tumor, the answer might be something like radiation alone instead of surgery. So we'll use this question as a segue into discussing the mediastinal nodal stations. This actually does come up probably every ab site in terms of which stations you can access with which staging modality and where the stations are. And it seems really confusing because there's a lot of numbered stations and they're left and right, but the way to remember it is it's actually very simple. So Todd, which of these nodal stations is correct? No, no. Try again. Not quite. No. Yes. So periaortic is number 5. If you'd like, you can come say that into the mic. Okay. And then so, oh, excuse me, periaortic is 6, but it is not any of what you guys said in terms of hilar, subcarinal, or retrotracheal. Sorry, this presenter view, I'm getting ahead of myself. But okay, so which lymph node station is not accessible via mediastinoscopy? This is a difficult question, but if you think about a mediastinoscopy, you are placing your mediastinoscope immediately anterior to the trachea. So what is, we'll just say, what is level 3? Right. So that might be the correct answer in this setting. So that is not accessible via mediastinoscopy. But rather than memorize this image, I think the important thing, so there are double-digit and single-digit nodes, right? There are pleural and mediastinal stations. All single-digit stations are in the mediastinum. All double-digit stations are in the pleura. The mediastinal stations, they just go from the top down. So your highest intrathoracic, your upper paratracheal is 2, retrotracheal 3, lower paratracheal 4, AP window 5, paraaortic 6, subcarinal 7, paraesophageal 8, and inferior pulmonary ligament 9. It just goes straight down. You don't, and we'll go through the different staging modalities. And then the 10 and out, they just go from the hilum out, right? So 10 is hilar, 11 interlobar, and then from there, they're basically all in the lung, right? So single digit mediastinal, double digit pleural. And then the other way that comes up is what is their end stage, right? N0, they have no nodes. N1, ipsilateral pleural, you just march across the chest. N1, ipsilateral pleural. N2, ipsilateral mediastinal, so ipsilateral single digit. N3, contralateral mediastinal, contralateral single digit. And either N4 or really it's a new site of disease. It's M1 if they either have a new or simultaneous lung primary, or they have M1 disease if it's contralateral. So supraclav is considered like N3, but that's not part of the mediastinal nodal staging stations. But so, and then the same thing, if you march across the chest, that also helps you determine how you treat these patients. So if they have N1 disease, you probably do not know that up front because it's not going to be assessed except with EBUS, but those patients can get surgery up front. If they have ipsilateral mediastinal, they should get neoadjuvant chemotherapy. If they have contralateral mediastinal, they are not surgical candidates. So single digits, double digits, you march across the chest in terms of N1, N2, N3, and you march across the chest in terms of surgery, neoadjuvant chemotherapy, no surgery. So those are just things to keep in mind because they'll try to trip you up with all these numbers, all these stations, all these things that we don't see a lot in general surgery, but you just stick to double digit, single digit, N1, N2, N3, march across the chest, and that also follows your treatment algorithm. So I won't ask these a ton, but we'll just go through them. Sorry. Yeah. And there is, if people are interested, it's probably beyond the scope of this, but there is a Thoracic Surgery Resident Association podcast on mediastinal staging, but it's for like card carrying nerds like me. But so yeah. So for these mediastinal staging modalities, they will ask you kind of what you can access, just kind of straight up. And so for mediastinoscopy, we talked about the scope goes along the trachea. And so you're basically going to access your upper and lower paratracheal nodes, your 2 and 4, and then your subcarinal, so 7. EBUS is a bronch, basically, that has an ultrasound on the end of it and a working channel. It's basically anything that you can access along the airway. So this is going to be really a lot of stations, but the same as mediastinoscopy, right? Because 2, 4, 7 are also along the airway. And then 10, 11, segmental and beyond, because those are just getting further and further into the lung. Excuse me. EUS is with an EGD. And so it basically has to be anything along the esophagus, right? So that's going to be number 8, because that's your paraesophageal. And then frequently you can get to your station 9 as well, because the inferior pulmonary ligament is, it's a medial structure. It's very close to the esophagus. So 8 and 9. And then does anyone know what a Chamberlain procedure is? On which side? Left side. Left side. Because at no point here have I listed stations 5 or 6. And so that's really what a Chamberlain procedure offers. It's pretty uncommon these days. For the most part, you can get to these with like IR guided biopsies and things like that. But that's the utility of a Chamberlain procedure. Is it gives you access to periaortic and AP window nodes. And then VATS is basically anything, because you're in the chest. But so they may ask something like this. These last 3 slides, that's basically how they ask this concept. Is basically, what is the nodal station? How can you access it? And then if they want to be difficult, they can ask, what should the patient get first? And same thing, you just march across the chest. Surgery, neoadjuvant, no surgery. This is a difficult question. If anyone wants to take a stab at it, otherwise we can move through and get to more frequently tested thoracic topics. But so someone with T1N1 would not be a stage 1B. T2N1, they may actually be a 2B. I believe it's T2N2 is correct, because a T3N1 would be a stage 3B, and then this person would be a stage 1B. But I'll send these slides out, but this is a reference that one can use. Basically though, if there's no patient with node positive disease, that is stage 1, and then N2 disease, you're automatically a stage 3. So again, N2 disease, ipsilateral mediastinal, you're automatically stage 3. You should get neoadjuvant chemotherapy. Okay. So Jamie, do you want to take a stab at this?
Either I'll go with B. No, D.
D is correct. D is correct. Yeah, that's accurate. Because they generally, you've been in tumor boards. It's not that different for thoracic, but they generally consider a node abnormal above 1 centimeter. CT is not, unfortunately, that predictive alone in the absence of PET CT. Greater than, I think sometimes people will use numbers like 2.6 or 4.6 for SUV uptake. And then this combining PET and CT does improve your diagnostic accuracy. So D is the correct answer. Let's see. Okay, so we just talked about mediastinal staging. This is a question basically asking what you can access with mediastinoscopy. Connor, you want to take a stab at this? Yes, good. Key to adult learning is repetition, so that's good. And then Frank, do you want to take a stab at this one? So I guess we'll just work through the choice A. Basically, is a segmentectomy as oncologic of a resection as a lobectomy? Correct. So it's not that. Do you have to do at the time of lung cancer surgery? I don't know if you've ever seen one in terms of a VATS, but do people typically do node sampling or a full lymphadenectomy? Correct. So a lymph node dissection would then presumably not improve your survival, especially for stage 1 disease. Tumors greater than 3 centimeters have reduced survival compared to smaller tumors. That's accurate. Good. And then we'll go to E. The majority of recurrence is local. Correct. Yeah, the majority of recurrence is metastatic. And so D is actually correct. Yeah, for completely resected stage 1 tumors currently, for the ABSITE, the recommendation will be no additional therapy. There's some stuff with stage 1B and above, and if they're EGFR mutated and those sorts of things. But for the ABSITE, completely resected stage 1, no adjuvant therapy. Let's see. Okay, some more kind of rapid fire things about lung cancer. You know, it's frequently tested that it is the most frequent cause of cancer death in the United States at a degree that, you know, outpaces the next 3 cancers behind it combined. So more than, I don't know what the next 3 cancer killers are, but those are most common cancers, not cancer killers, but more than the next 3 combined, basically. But the 3 that you need to know are going to be lung, colon, and breast in terms of top 3 cancer killers, and then most common cancers in men and women, you know, being respectively prostate and breast, and then on from there. What's the most common site of metastatic disease, Jamie? Yes. And then, not really, but you can say stage 2 disease and above basically needs brain imaging. So certainly anyone, as far as you're concerned on the, I'm sorry? Yes, yeah. 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 Okay. So specifically with, we'll say lung adenocarcinoma, is there any other organ that you need to look at on your CT scan, Todd? That's a good answer to a yes/no question. I guess I should say, what other organ do you need to look at? Not, is there another organ you need to look at? True. No, not the liver. Frank? Yeah, yeah. It's a common site, especially for lung adenocarcinoma. Sorry. And that's why really a CT chest to look for lung cancer, it does go through the adrenals. It does go through the adrenals. And what's the most common type of lung cancer? That's an umbrella term, but within non-small cell, what's the most common type? Yes, it is. And then what's the most common type in non-smokers? It's a different. What's the most common type in non-smokers? Don't overthink it. No, adeno goes to adrenals. Most common is adeno. What's the most common in non-smokers? Still adeno. So just keep that in mind. Okay. It's, you know, a precursor lesion. People will talk about bronchoalveolar carcinoma. It will look like an old pneumonia. Some people say it grows in the scars of old pneumonia. That's people putting the chicken before the egg. It looks like a pneumonia. It is not a pneumonia. It's precancerous. But the most common treatment for small cell carcinoma, this is a small round blue cell tumor. You know, the biology of this disease anywhere in the body is chemo and XRT. It's almost never surgery for small cell carcinoma. And then if you had to choose between typical and atypical carcinoid, which would you say had a better prognosis, Serena? Yeah. And then the treatment for mesothelioma. It's kind of a trick question. You know, you could say extrapleural pneumonectomy. Those patients don't do great, but extrapleural pneumonectomy is the answer if it is isolated to that pleural space. But it's highly morbid. These patients are highly selected, and they still don't do great. Okay, some other thoracic tumors. So which is correct regarding germ cell tumors of the mediastinum, Jamie?
I would say it's the last
Not quite. So there can be a role for residual seminomatous disease after they get chemoradiation. For C, we'll just work backwards. So seminomas are typically very radiosensitive, so the cure rate would be higher than 50%. In your textbooks, a pure seminoma will be primarily an HCG elevation, but seminomas can definitely have AFP elevations too, but their primary elevated tumor marker will be a HCG. But this is one of those kind of test taking skill questions where, choice B is a very absolute answer, which should to some degree maybe steer you away from it because there are exceptions to many things. And so A is correct. It will count. So seminomas will be your most common germ cell tumor within the mediastinum. Can anyone recite kind of the terrible T's mnemonic for anterior mediastinal masses? I guess not a yes/no question, but if anyone would like to, please recite the. It's two of them. So thyroid goiter and terrible lymphoma. So this would fall under, this is not a teratoma, but you should think of germ cell tumors. Would be a better, more broad way to think of that. And then what is most common, anterior or posterior mediastinal masses? And then the most common type of a posterior mediastinal mass, just broadly speaking. Yeah. Okay. So now that we're talking about neurogenic tumors, Connor, any thoughts? What's it?
I've never seen that word before.
What word?
Neuroendometrium.
It's a real word. I would encourage you to go read about it. But are these tumors more common in children or adults? Let's go through A. Correct. So it's not A. So when present in children, they're invariably benign. Agree? A neurolymoma is a malignant variety of a nerve sheath tumor. No. So that would be something like a neuroendocrine carcinoma, right? Neurolymoma, that is a phrasing just in terms of cancer syntax, things that are omas as opposed to carcinomas is a way of differentiating benign versus malignant. Neurolymoma is generally a benign nerve sheath tumor. Most patients are symptomatic. Correct. Yeah. I mean, most of these come to our attention as a result of imaging for some other reason. And then how about a ganglioneuroma is a tumor of the sympathetic nerve system? That's accurate. So that's the name applied to essentially an extra-adrenal pheochromocytoma, right? And so what might you check before taking a patient with a ganglioneuroma to the operating room? Or if you think it's a ganglioneuroma, what would you check? What lab might you check? You could start with their urine or their serum. Yeah, right. Because having someone have a hypertensive crisis in the operating room is frowned upon. But that would be just things to think about, ways that they can ask this question. Todd. Yeah, which is true of forces. Not quite. They're a little more common in adulthood. So we'll go through them. A simple cyst, is it likely to be unilocular or multilocular? Good. Pleuropericardial cysts are the most common variety. I agree. It's unlikely for them really to be both. That is an infrequent variety. Bronchogenic cysts we kind of touched on this, but they're more common in adulthood. And then the last one, esophageal cysts should be treated with needle aspiration. I agree. Yeah, you should not just do needle aspiration on those. Those can be formally resected, and if you needle aspirate them either extraluminally and cause a leak, that's frowned upon, intraluminally and cause scarring in a manner that makes your resection more difficult, also frowned upon. So foregut duplication cysts are frequently diagnosed by imaging alone and then resected. But so D, a pleural or pericardial cyst, they typically do not communicate with the pericardium. Okay. Frank, which of the following is true for thymomas? So the thymus lives in the intermediastinum. So do you think 75% or even more are in the intermediastinum? Yeah, like 95+% are in the intermediastinum. Then working from the bottom up, the Masaoka classification has been shown to have prognostic significance. It's more of a histologic classification system. There's no great staging system. There's new AJCC, but basically it just allows us to classify them so that we're speaking the same language when we're talking about thymomas. Because previously there was like 40 different subtypes, and it's not useful to talk like that. It should be lymphocytic, not lymphocytic. Subtype has the best prognosis. I agree. And then about 50% are an epithelial subtype. That's correct. So what about B? That's true. Distant metastases are rare. Even if these are malignant, usually they behave in a malignant fashion locally, or they can have mediastinal recurrence or pleural seeding or those sorts of things. That's how these patients do poorly and end up dying. It's not from distant metastatic disease. Yeah, tend to be locally invasive. It's more that they are prohibitive in terms of their resection risk and things like that. Yeah. This is really a brief table summarizing kind of most common components of mediastinal masses in the different mediastinal compartments. We won't really belabor that too much, but so this is good, and this actually comes up probably every now and then, especially on trauma and NACS. But in terms of a lung abscess, Jamie, which of the following is true? I'll tell you, it's not A. We don't get hung up on 4 weeks or things like that. That's true. Yeah, people will talk about superior segment of the right lower lobe in the setting of aspiration. And so if we're thinking that aspiration is more common, that probably also takes away B. It's more common for people to have aspiration events than to have obstructing endobronchial lesions. Right. And then, so you're kind of between D and E.
I mean, I guess you could have pumps that's not like super.
Yeah. Yeah, E is the correct answer. I think. Yeah. I think that's something that people forget is, a lung abscess is, we talk about not entamoeba histolytica abscesses as, in the liver, the one abscess in the body that you don't need to drain, right? You treat those with flagyl. Lung abscesses are probably the other quote unquote common abscess in the body that you don't need to drain. They are de facto draining through the tracheobronchial tree, and the lung has an excellent dual blood supply, right? So that's the physiology of why you can get away with treating these with antibiotics alone. When they are, and there's a difference between a lung abscess and an empyema, and that being if they're which side of the pleura they are on, and empyemas must be drained. So people conflate the two, or they see a lung abscess and they want us to drain it. The therapy is not to stick a tube into the lung for a lung abscess. They are already draining unless they have some obstructing endobronchial lesion. Yes, again, not stick a tube in the lung. Just you're not going to wait out their air leak. But Frank, so which of the following is true regarding diagnosis of lung abscesses? Yes. We talked about it a little bit in terms of these typically not needing drainage. Some of the, like C is kind of unfair and confusing, but said D?
Yeah.
Correct. Yeah, medical therapy is generally successful. And for patients that then have bleeding complications and those sorts of things, that's when you can, or they have a necrotizing pneumonia or something like that, that's when you can entertain, like lobectomy or non-anatomic resection for refractory lung abscesses. Empyema is a different modality. Patients can have perineumotic effusions that get secondarily infected. That would be an empyema. That is not a lung abscess. It's really kind of totally different. But we do talk about kind of the different stages of empyema. There's an initial exudative phase where they have acute inflammation. They're starting to have kind of the setup of their initial infection. This is when you would like to intervene, when you would like to drain it. If you're going to do TPA and Dornase, that's fine, but this is when you want to administer it because this is when it's going to work. And then you have the fibrinopurulent phase, it's kind of maturing, and then organizing phase. This is where you get to the point that a patient is probably only going to have success if they have a decortication, just in terms of your likelihood of unfreezing that lung. Yeah, and then Staph aureus being the most common bacteria. This table on the right, you probably don't really need to know, but the last bullet, just to say that cultures are negative or misleading fairly frequently. So even if you think you have it isolated, drainage is the name of the game. And in healthy, well-selected patients, I would, if they have a sizable empyema and they're healthy, young, and they can tolerate, I would go immediately to a VATS decortication. I would not, the TPA and Dornase is meant for people that cannot tolerate that. They're older. I mean, the outcomes in those studies are like avoidance of surgery at 3 months. It has nothing really to do with resolution of the empyema. So just things to keep in mind, because I think we apply that study to lots of patients that it's not meant to. And then, so I gave a talk on this probably a few months ago, but Connor, when you're thinking about doing pulmonary metastasectomy for various general surgeries, kind of cancers like colon, for instance, what would not be a selection criteria for something like that? So we don't care so much about that. You can wedge out lots of things. So that's the correct answer. Sorry, I was forgetting that this was a negative question. But so you have to be able to control the disease. You have to either have controlled or be able to control the primary tumor site. They can't have so much comorbidity that they can't tolerate the resection. And then whether or not there's a superior alternative is debatable, but if you're going to offer someone surgery for metastatic disease, it needs to be the best treatment option rather than just offering them the morbidity of that resection. So A is the correct answer. Typically people will say ideally 3 or fewer Mets. That's dogma. It's not really based on much other than very old observational data. So if someone is a good risk candidate and they have 4 or 5 and they're not peppered with disease, you can still offer them metastasectomy. Okay. Jamie, a trauma question. So which of the following is true regarding blunt tracheobronchial injuries?
So
Correct.
That's right. Opens bronchus, I guess that means right. Opposite is not necessarily peripheral, probably not A.
Correct. Yes, most are due to motor vehicle accidents. So you said D is not correct. How do you approach the proximal left median bronchus?
The proximal, I think, like I said, proximal 1/3 approach to the right.
Yeah, you should approach to the right chest. Yeah, the aorta will be in the way. So this is just an image kind of showing the various approaches to the airway. Obviously you can make a cervical incision. You can extend that with a collar incision between your incisions that are anterior to the SCM on both sides and access the upper airway. Sternotomy for really high stuff, but pretty quickly the heart is going to be in the way. And then, yes, the key to remember, if it's carinal and proximal third to the left, you still approach it from a right posterior lateral thoracotomy. We're just going to move through some of these a little more quickly to get to some rapid fire stuff. So which of the following is true for penetrating injuries to the heart? Stab wounds carry a higher mortality than gunshot wounds? No. Ventricular injuries, worse prognosis than atrial? Actually, no, because they tend to be able to self-tamponade and those sorts of things. So when you repair them, there's actually something to sew to. It's not just a shredded atrium. Hemodynamically stable patients with a pericardial effusion can be observed. Don't do that. Use of a Foley in the is a safe, effective method of controlling a ventricular defect. I would shy away from this. It's shown in some trauma textbooks. I think that's it can be done. It's not definitive, I guess, is what I will say. But obviously, an intrapericardial injury to the aorta is a high mortality. That's something that this patient's going to rapidly develop tamponade and probably arrive dead. Yes, you can temporize them with that. It's also probably better for your atrial injuries but yeah. Because the other thing, if it's ventricular and it's not totally shredded, just someone puts their finger on it, and that is their one job until you're ready to operate. Yeah. Okay, so cardiac surgery is also simple, like thoracic surgery. If it is blocked, you bypass it. If it doesn't work, you repair or replace it. If the heart isn't working, just fucking take it out.
Replace it.
Yeah. If the aorta is abnormal, you replace it. So most common cause of death in the country, Jamie? Not a trick question. Yeah, coronary disease. You arrest the heart in systole or diastole, Todd? Relaxed or contracted? You want the heart to sit in a contracted state for an hour and a half. Right, so relaxed. So what's that called? Yes. Most common benign tumor, Connor? Yep, atrial myxoma. Malignant tumor, Frank? Just think, the heart is a big blood vessel, so an angiosarcoma. We won't run through these or the various forms of shock, but it's uncommon. This comes up really more so in like a critical care setting. They'll ask you about, wedge pressures and those sorts of things. And then I think we get plenty of this in critical care as well. Which of the following is not predictive of early mortality after coronary artery bypass? This is a difficult and probably unfair question, but male gender, actually. Female gender is actually associated with higher mortality. There's some thought that it's related to generally women with coronary disease being older, more frail than their male counterparts. Also, their target vessels are smaller, so it's just more technically difficult sometimes. The other things seen here are predictive of mortality after heart surgery in general. This question is probably not going to come up, but whether you skeletonize or do a free pedicle is fine. So which of the following is not a risk factor for death in patients with coronary disease? Just hypertension. Patency rates, so Lima, 90%, radial 70-80, saphenous at 10 years, 50-50. There's some thought that, saphenous grafts are just about as good as stents, but just stuff to keep in mind. So, okay, this is a little more germane. We'll kind of get into some physiology of some valve disease. So which of the following is true regarding the clinical presentation of aortic stenosis, Todd? Correct. It is actually D, yeah, but just something to keep in mind because these patients have kind of a fixed stenosis, the inability to kind of augment their outflow, and basically they will syncopize if there's a change in kind of downstream resistance. They won't really be able to augment across that fixed obstruction. They'll get a reduction of blood flow to the brain and pass out. The ways in which people become symptomatic from aortic stenosis, this diagram shows angina, syncope, and heart failure. Excuse me, another way to think of this is angina, syncope, and dyspnea. So people will use the mnemonic ASD. That is the manner in which people become symptomatic from aortic stenosis. They either have angina, syncope, or dyspnea, and that correlates with your predicted time frame of mortality of 5, 3, and generally 1 to 2 years. So which of the following is true for the natural history of mitral valve disease, Connor? So geographic location is going to influence whether or not it's kind of native valve or rheumatic disease. So it's not A. And then from the bottom, patients with hypothyroidism have an increase. That's not true. It's sometimes associated with hyperthyroidism. Patients with mitral stenosis are more likely to have had previous episodes of rheumatic fever. Not necessarily true. You can have mitral stenosis without episodes of rheumatic fever. And then left ventricular function, it does not deteriorate in a predictable manner there. So it'd be B, because if you think, your atrial kick accounts for about 20% of your left ventricular preload and thus your cardiac output. And so if you have mitral stenosis, that atrial kick is going to actually be relied upon even more so for a greater percentage of your cardiac output. And so when you lose that in the presence of atrial fibrillation, those patients that can be the only thing that tips them over into decompensated heart failure, is whether or not they're in or out of atrial fibrillation. So it's a very important thing in patients, especially with mitral stenosis, but regurgitation as well. Yeah. So which of the following is not a major diagnostic criteria for infective endocarditis, Frank? There's major and minor. Honestly, if you don't have to know them so much, but if you look at these, one of these criteria seems like less of a big deal than the others. I mean, patients fever for a host of reasons. So it's not a major criteria, it's just a minor criteria. If you have new echo findings to include valve regurgitation and a positive blood culture with a typical organism, those are all major criteria. That's the end of some of the earlier slides by Dr. Percival that were updated, and then we'll kind of blow through some of these. We have about 10 more slides. So all the following are indications for thymectomy in patients with myasthenia, except, Todd? It's actually A. Isolated ocular symptoms, for whatever reason, do not tend to improve as much with thymectomy. So patients certainly that have generalized weakness are those that would benefit the most. And all of these choices have that in some form. It's important to remember, patients with myasthenia, what percentage of those have a thymoma? Yeah, it's like 10%. But what percentage of patients with myasthenia get better with a thymectomy? It's like 70%. Yeah. And of the patients with thymoma, how many of them have myasthenia? It's like 30%. Yeah. That's still the presence of a thymoma is an indication to resect. And then for most patients that are good risk and have something other than ocular symptoms alone, the presence of myasthenia it can be an indication to resect. Okay, so a 47-year-old guy, homeless woman, excuse me, comes in with cachexia, blunting of the right costophrenic angle. Which of the following is true? This is going to be based on their pleural fluid analysis. Jamie. So so if they have blunting of the costophrenic angle, that's an obvious effusion. You don't necessarily have to get a CT in terms of getting rid of choice E. Tuberculous effusion can be readily identified by stain and culture. It's very difficult. Tuberculosis is very difficult to both stain and culture. The presence of a bloody effusion confirms the diagnosis of an underlying malignancy. That's too definitive of an answer choice, right? And then B, a pleural effusion glucose lower than serum is diagnostic of an empyema. That's not true. The diagnosis of a complicated pleural effusion would be glucose less than 60, pH less than 7.2, presence of frank pus or positive cultures. And then so A, if it says lymphoma, so they have a very lymphocytic pleural fluid collection, what else might that be? In a homeless person who's malnourished and things like that, it could be TB, right? They would have a very lymphocytic response. So it doesn't mean that they have lymphoma just because you see a bunch of lymphocytes in their pleural fluid collection. That's what A is getting at.
Okay.
Whenever they give you someone who's like homeless, cachectic, they're probably trying to get at something opportunistic. Yeah. Let's see. So which of the following has the least influence on the appropriateness for lung resection in a patient with a 2 centimeter right upper lobe nodule, Frank? Yeah. I mean, age is a number. It's more important their physiologic age, and then all of these other things have much more to do with their actual cancer staging than whether someone's 50 or 60 or 70. This is a little bit of a difficult question, but Connor, the initial improvements after lung volume reduction surgery and emphysema. It gets back a little bit to some of those flow volume loops we were talking about. Is there anyone else? Oh, okay, Beth is still listening. Okay. So it's elastic recoil. It's not so much that there's compression of the adjacent lung, but you now have a lung that's more uniform and can expand and not air trap and things like that. Let's see, Todd, a 59-year-old man underwent malignant removal of a tumor 2 years ago. He's a solitary pulmonary nodule now. For him to be considered an operative candidate, which of the following must be met? I'm sorry? I think he underwent resection of something else, like a sarcoma or something like that. So this is in reference to metastasectomy. So it's not A, right? We don't talk about tumor doubling time. Must be possible. Correct. It is not E. Correct. That's nonsensical. And then B, that didn't make a ton of sense, right? like even if other therapies are available, we're just going to resect. So C is a pretty good one. And I would say a better phrasing would be that it must be controllable before that, the sequencing of therapy doesn't matter per se, but it must be controllable rather than necessarily being managed. Let's see. Okay, so this is probably the only esophageal question we'll talk, or esophagus related questions, really the thoracic duct. But patient undergoes extrapleural pneumonectomy, chest tube output greater than 1 liter, 3 days post-op. It has a triglyceride level of 300 and is very lymphocytic. He's NPO, zero fat diet. He still has the same chest tube output. You're 3 days post-op. What do you do next? So what is his diagnosis, Jamie? Yes, yeah, from a thoracic duct injury, presumably. And so triglyceride level greater than what is diagnostic of that?
Like 130.
110, yeah. And then, lymphocytic is very common. It's actually like back in the day before they had immunosuppression, they would drain people's thoracic ducts to deplete their lymphocytes before solid organ transplant. Seems insane because it is. But so the things to think about, he has high output, uncontrolled, early post-op state. So are you going to you're going to continue the NPO? You're not going to do that. That's what's got him here. Pleurodesis. If he is filling up at 1 liter a day, that space is going to refill. It's going to push the lung away from the chest wall. Your pleurodesis is going to fail. Tissue expanders in the post-pneumonectomy space, people will do that to occupy space. It does nothing to control a chyle leak. And then E, bronchoscopy, fibrin sealant. It is not a bronchial stump leak, right? That would be if you were far out and it was prohibitive to go in and address a bronchopleural fistula, which this patient does not have. So operative ligation for the early high output uncontrolled leaks. That's the time that you would use it. In terms of times that you would use thoracic duct embolization, that might be in someone who's like totally deconditioned, very sick, a little bit further out. So diving back in would be prohibitive. It'd probably be a lower output than 1 liter. It'd be like in the 300 range, and they're like a week or more out. And then in terms of trying your conservative therapies first, someone who is not septic appearing, someone who has a controllable leak that is relatively low output. Okay, they put this topic in thoracic because it's thoracic outlet syndrome, even though it's very much a vascular topic. So Frank, the just normal anatomy from anterior to posterior of the thoracic outlet. Right, so the difference is you have vein, nerve, and then it's A. So the only structure outside of kind of that pyramid of your scalenes is the vein. And I mean, phrenic nerve, but in terms of things that you would decompress in the thoracic outlet, your artery and brachial plexus are between your scalenes. So it's A. A little picture of it here. This picture is not great because it doesn't draw the phrenic, right? That's a problem. But this shows kind of the area of decompression once you achieve your kind of scalenectomy and kind of take this whole little block out, how that would free up, that space. So just something to have in mind. And then obviously there's the subclavius muscle and subclavius tendon. If they ask you about that, that's going to be the only thing that's more interior. Okay, getting down to the wire. We have like 3 more slides. Patient with known aortic stenosis. I'll just go through these and then we have rapid fire questions. So known aortic stenosis develops angina and an episode of syncope, which the following is true. Onset of angina indicates he must have concomitant coronary disease. That's not true. You can just get that with isolated aortic stenosis. Presence of angina is an indication. Percutaneous balloon valvuloplasty should be considered. No, that's for the most prohibitive risk patients only and has a high risk of stroke. He's not an operative candidate because he has not yet had heart failure occur. That is ridiculous. And so the presence of angina is a indication. That's just what we talked about. That's ASD in terms of the ways people become symptomatic with aortic stenosis, angina being the first one. If you have symptomatic aortic stenosis, that's an indication for surgery. And then, so someone is a 42-year-old woman is noted to have exercise intolerance. She has a opening snap in the mitral area, suggestive of mitral stenosis, which the following is true. So severe MS is defined as an orifice area less than 1 square centimeter, so that's wrong. Depressed cardiac output is due to depressed myocardial contractility, false. And then with a fixed mitral orifice, change in rhythm from sinus to AFib has little effect on cardiac output. We just talked about that. It has a significant effect. So the presence of mural thrombi and thromboembolism are directly related to AFib. So that's B. Okay, rapid fire. PFT parameters you want for a lung resection. Just give me your post-op predicted FEV1 and DLCO. Greater than what? That's your pre-op number, an absolute number, but post-op predicted, greater than 40, correct. You want a PCO2 of less than 50 and a PaO2 of greater than 60. Strongest influence on survival with lung cancer, Frank? You said it earlier? Yep. Paraneoplastic syndromes associated with squamous and then small cell. Yeah, squamous is PTHRP, and small cell, small cell, it's a small round blue cell tumor. It can be hormonally active. I'm sorry. You said ACTH, so that would be not Addison. That would be the opposite of that. It would be Cushingoid, right? And then another hormone. Yes, SIDH. When is mediastinoscopy indicated? That's kind of but so you want to assess nodal status of one of those stations we talked about, 247, basically. Most common benign lung tumor, they might describe it as a popcorn calcification on an X-ray. It is disorganized but mature tissue. You'll recognize it when you see it. It's a hamartoma. There's only one M. I don't know why that's misspelled. Most common mediastinal tumor in children, just big groups tumors, like blankogenic. Most common mediastinal tumor in children. We said they're most common posteriorly. Yes, neurogenic tumor. Most common early complication of tracheal surgery. This is difficult, but just laryngeal edema. And then late complications, or just tracheal, like resection, kind of granulation tissue and like restenosis in some fashion. Surgical treatment of a tracheoinnominate fistula. Yep. Like, and then you way to prevent it is, placement of your trach in the appropriate position. It is not. It is not to put an interposition graft that will blow out and they will die. Location lung abscess, superior segment, surgery for pneumothorax. You do it in those that recur second time. They have a high risk profession. They live in remote areas, prolonged air leak. CHF in children, hepatomegaly. Most common congenital heart defect is a VSD, indication for cabbage. They probably won't ask us this, but left main disease, 3 vessel disease, 2 vessel disease in diabetics, or that's not amenable to stenting. I'm sorry? No, it's VSD. Yeah. I think many of them close spontaneously, unlike ASDs. That might be part of it. But most common valve lesion that goes to surgery is aortic stenosis. Worldwide, it's mitral insufficiency. Indications for operations for aortic stenosis. Yeah, the manner in which patients become symptomatic. So if it's symptomatic and then really a peak gradient greater than 40 demonstrates severity. Endocarditis, staph, and Pseudomonas in drug users. We talked about benign and malignant myxoma, angiosarcoma. When to reoperate for mediastinal bleeding, greater than 500 in an hour, greater than 2. It really, the other way that they'll give you this is a patient is having lots and lots of chest tube output, lots and lots, and then it stops and they become hypotensive. So they have clotted their mediastinal tubes and they have developed tamponade. That is the vignette that you should look for, not asking a general surgery resident when they would reoperate on someone else's cardiac patient, right? So look for that vignette. Someone is dumping, they clot their tubes, they have tamponade. When to operate for mitral regurg, symptomatic, complications of an MI, septal rupture, papillary muscle rupture. Okay.